I'd just like to firstly thank you for this opportunity to discuss gadolinium contrast agents with you. I feel like this topic is vitally important, and so yeah, thanks again for agreeing to do this.
Oh, it's our pleasure. So I've got the entire team here, or the majority of the team. I've got Dr. Escobar. She's our research scientist 3 and a veterinarian. Julie Harris, she's the program manager of the Kidney Institute in New Mexico. And we've got Josh De Aguero. He's our graduate student from the Biomedical Sciences graduate program. Fantastic. And I do have a preamble. Nothing that we say represents the views of the University of New Mexico Health Science Center or the Kidney Institute in New Mexico, or those who fund us, which is the Dialysis Clinic Incorporated. And it doesn't represent the views of the Veterans Administration, which also provides us some funding. But that being said, I am the director of the Kidney Institute in New Mexico. And I'm also the acting Associate Chief of Research for the VA here in Albuquerque, and the Renal Section Chief at the VA too. And so I just need to get those titles out in order to provide this interview.
Yes, that's very important. As you've said, it's very important to be careful about what you say and how you say it. I understand that you've communicated a lot of information which may be seen as controversial, because with these gadolinium-based contrast agents, over many years they've been deemed completely safe. But recent evidence has come to light, some of which you have produced yourself, stating that this gadolinium is retained in tissues. Could you expand just on your background in terms of what you do and how you got involved with looking at these gadolinium-based contrast agents?
Sure. I'll start with the last question. So in 2006, gadolinium was pinned on a horrible disease, a ghastly, debilitating disease that was sometimes fatal, and they termed it nephrogenic systemic fibrosis. And as you know, I don't like the term nephrogenic because it promotes a collective blindness. Nephrogenic means that the kidney is causing something. And if you have renal patients that have not been exposed to gadolinium, they just simply don't get this horrible disease, which is characterized by widespread fibrosis. It's thickening of the skin, joint contractures, which is a fibrotic process from the joints and the tendons. And they recognized that the gadolinium was absolutely the cause of it in 2006. And I'm a clinical nephrologist. I have a number of dialysis patients who had been exposed to gadolinium. And what was curious is that some patients received a lot of contrast examinations. Some would receive just one, and maybe they weren't even on dialysis, and they still contracted this horrible disease. So there's something mysterious there about why some people get the disease and others do not. And so that prompted our interest in researching this. Gadolinium, it's a rare earth element, and as a nephrologist, we study the composition of the body, which is the electrolytes and the minerals. Well, rare earth elements are not physiologic, they're not biologic, no matter how far back you go in evolutionary history. So among none of the vertebrates for 550 million years of evolution, do they use gadolinium or any rare earth element as a trace element. And so the fact that we are injecting patients with this, because it's ideal for magnetic resonance imaging, we're injecting patients with this, and it turns out in 2017, it was absolutely clear that people are retaining the metal. And this was first discovered by Japanese researchers, where they found an abnormal signal on brain MRIs, where the dentate nucleus had a very strong signal. And when they looked at the histories of these patients, they found that these patients had been exposed to gadolinium-based contrast repeatedly. And all of a sudden, on non-enhanced images, this signal popped up. And so this prompted a lot of concern worldwide. The European Medicines Agency, the FDA. And so our FDA convened a meeting in 2017. It was September 8th, 2017. They invited me to provide the introductory lecture about what we know about the biology of these gadolinium-based contrast agents. And then the rest of the day's discussion was based on retention and patient safety. And so from our models, I think it's pretty clear from human data that trace amounts of this rare earth element get retained in the body throughout. And it's in every vital organ that we've examined. Actually, we've got Dr. Doe. Come on in here, Dr. Doe. This is another part of our team. Dr. Catherine Doe, she's the first author of many of the papers. Dr. Doe and I published in 2014 in the American Journal of Physiology. Dr. Doe was able to detect gadolinium in every organ that we looked at. And so trace amounts of this stuff are being retained in the brain and the muscle and the bone. And how this operates, how this affects the physiology of this normal cellular function is something we're very curious in. And so it's clear that patients, when they're exposed to it, they retain amounts of it throughout. It seems like some patients get symptoms, a lot of patients do not. But we're curious about the patients that do get symptoms. We're also curious about, in those patients that don't get any symptoms, what is it about their composition that renders them impervious to the effects of having a rare earth element inside their cells.
On that topic, how are you able to quantify this? Are there a number of measures, and what would you do if, say, someone is having several scans over many years using this contrast agent? I know the effect is cumulative, so if these trace amounts of the gadolinium retained is then happening over over a long period of time, what
Right.
kind of effect can we see, and how can we attempt to mitigate this or remedy this if there's a greater level?
Well, from our standpoint as clinical nephrologists and in this field, our very first question is, does a patient need to have gadolinium for the scan? And you mentioned on one of your podcasts, you brought up this question, and the answer was no. We don't need the gadolinium contrast in the least to find what we're looking for. Is that accurate?
Yeah. So when would it be necessary? That's the question, I guess. There's clearly some need for it, otherwise it wouldn't be there. But in what circumstances would the benefit maybe outweigh the risk?
Right. And in that realm, I can't say. That's not our field. As nephrologists, we're concerned about number one, our patients are those with renal insufficiency largely. And so we're very concerned about what cannot be undone. And so my default position is you can never undo gadolinium exposure. Can you get the exact same answers without gadolinium? And if you can get those answers, maybe you should pursue those tests first. I'm not an absolutist. I know that there have to be instances where gadolinium made the diagnosis. But the problem is that I don't see those data. And that brings me to another position. I do believe that patients should be told what they're getting. I know that when we receive vaccines, we have to consent for every vaccine that we receive. And there's nothing more life-saving than vaccines, nothing. And yet we give our consent for it. But the way that the FDA wrote its conclusions after 2017, and also the Canadian Association of Radiologists, they leave an exit to where gadolinium can be given without the patient's consent. And for me, if you're going to be doing this, It shouldn't be done after the Nuremberg trials, number one. You should be able to tell your patients about what you're doing and this unknown risk of when patients are going to retain the gadolinium for a long time. I think patients have the right to ask if other procedures can be done. So once it's been done, I really can't say. This is an open frontier. What we do know about the gadolinium is it does enter the cerebrospinal fluid within minutes of administration, and that's even if you have an intact blood-brain barrier. They can detect it in the cerebrospinal fluid within minutes. And as nephrologists, this means that it's a compartment that the kidneys can't clear. It's definitely a compartment that we cannot touch with dialysis. We know that the gadolinium, it gets inside cells. And this is some of our research here in Albuquerque, where we are on the electron microscopes nearly daily, finding gadolinium within the cells. And a group at Mayo found that this gadolinium can be within the brain cell neurons and even within the nuclei of those neurons. And it starts to form these nanostructures, these spiculated electron-dense nanostructures. Now, my critics will say, that's fine. No one shows any symptoms, even though they have these nanostructures inside probably every cell in their body. So therefore, they conclude that it's safe. Our concern is what's going to happen 10 years from now, 20 years from now. It takes a very highly powered study to detect these adverse effects. So a lot of our questions are on the front end. Do you need to have the gadolinium in the first place? Now, you asked about the testing. There's the only CLIA certified labs that I know of that will test for gadolinium are at the Mayo Clinic in Rochester, where they will test 24-hour urines for gadolinium. They can test the serum for gadolinium, and they can test paraffin-embedded skin for gadolinium, but only under special circumstances. Otherwise, the monitoring, I don't know, but it's something that we're interested in, because people seem to harbor this non-physiologic element for many years.
And have you looked at patients over a course of time? So for a prolonged period, have they shown increased symptoms, and have you been able to monitor that?
You know, it's anecdotal. It's people calling us and reaching out to us. But it does seem that patients with normal renal function who do have symptoms, I have heard of patients getting better. But this has been over the course of 10 years.
And if you do get tested and you do find that you have this gadolinium toxicity, you're saying that it's difficult to know. It's difficult to know what you can actually do about that.
Yeah, that's my position, and we're talking about with nephrogenic systemic fibrosis, or it should be called gadolinium-induced systemic fibrosis. It's a rare disease. You know, a lot of people get contrast, and they appear to be symptom-free afterwards. But for those patients, I forgot what was the question. It leads up to this. So for these patients with renal insufficiency, they can't get rid of the gadolinium whatsoever. With us with normal renal function, at least if you find the gadolinium in the urine, that's telling you that the body is still getting rid of the urine on a daily basis. Now, the gadolinium-induced systemic fibrosis is a rare disease, so that makes it almost impossible for us to study prospectively. It makes it very difficult to study retrospectively because the numbers are relatively small. That limits the power of the studies that we're going to be that we'll be conducting. So this is why laboratory experiments are so important. Is we need to find out what is the cause of the disease on a molecular basis, so that we can approach those targets as well. And I think that's going to be the only way that we make progress in this realm. And then with patients who do have the symptoms, we need to define what symptoms are most likely from the gadolinium, what symptoms are ancillary, and then we can construct better prospective trials to see if we can blunt these molecular targets, and if that assists with any of the symptoms.
I understand that with healthy kidney function, you can have retention in tissues. What would be the mechanism behind that?
There was a paper about a month and a half ago that showed that if you incubate red blood cells and white blood cells with gadolinium-based contrast, both cells, they gobble up the contrast. White blood cells a little bit more because that's largely their nature. With red blood cells, this gadolinium, it's somehow penetrating the cell membrane and entering those cells. We study kidney cells quite a bit. We believe that it might be the cells taking it in from the what they call the apical side or the urinary side, and but it's also possible that that there are transporters on the opposite side that are recognizing the molecules and trying to shuttle them into the urine. So it could go either way. Now for neurons, I'm not entirely sure how it got into the neurons and how it gets into the nuclei, but as you see with all these questions, it's a very large realm for research. And also it could help design safer and better gadolinium-based contrast agents. People term these some of these brands as being new agents or second generation agents. When you go into the literature, when you do a PubMed search, all these agents were being studied in the 1980s and 1990s. So some of these agents that they call are new actually had a debut in the medical literature in 1994. They're not new at all. None of them were designed to prevent nephrogenic systemic fibrosis. And if we know more about the biodistribution of these, then we could design better contrast agents.
So are there currently any alternatives that would be likely safer, or is this something for the future?
That I can't say. I know that there is a group that Peter Caravan is involved with called Reveal Pharma. They have a manganese-based contrast agent, and that I believe they did some presentations at the most recent RSNA meeting. The FDA recommends, number one, if you don't need to use it, don't use it. If you have a life-threatening and compelling reason to use the contrast, to use it at the minimal dosage that you possibly can. And I think every agency recommends to avoid repeat exposures. But this is also, this is outside of our realm. We're interested in the physiology of having a rare earth element in the body and how this impacts the function of the cells.
Yeah, I was about to ask just what you've discovered that you found most interesting that you maybe hadn't thought of before, or any kind of results that led to some concern, or something that you would like to understand more about, maybe.
Yeah, I think we are, even though we're trying to contribute to the scientific literature as much as we can, we're still at ground zero with understanding how this contrast agent, how it impacts physiology once it's administered. I think some of the more interesting studies is Dr. Doe's publication, where she did a head-to-head comparison with two different brands of MRI contrast. She found that there were differences in histology. When we looked at some of the organs, especially the kidney, they both affected the kidney the same. But different agents seem to lead to different degrees of retention in each organ. We discovered that bone marrow remembers that it has been exposed to gadolinium before. So if you prime bone marrow, and then that bone marrow happens to see gadolinium again in the future, it responds with a more severe reaction. And that was unexpected, but that was also interesting. We look at some of the chemical mediators that are turned on by this toxicity. We discovered that the monocyte chemotrectin protein 1 seems to be liberated from target organs, and this attracts bone marrow cells to affected areas. And one of the more interesting things, it was an experiment that I didn't think was going to be worth doing, but we had a wonderful French collaborator, Dr. Yves Gorin, who suggested that we look at the metabolomics, we look at the metabolic aspects of gadolinium. And we found, it was surprising, but gadolinium induces insulin resistance. It induces hypertriglyceridemia. It induces hypercholesterolemia. So it's got some kind of effect on liver mitochondria. And then when we look at the kidneys, gadolinium-based contrast induces what's called the Warburg effect. I'm sure you have heard of the Warburg effect, which is, it was described in cancerous cells that they undergo a energy switching. They start to rely on glycolysis more than they rely on the energy produced from the mitochondria. And so in the kidney tissue, we found the Warburg effect. We found that lactate increases, that glycolysis increases, whereas the pathways handled by the mitochondria were actually suppressed. And so this is very remarkable for something that for years everybody has been saying is inert. It's an inert substance. It has no biologic consequences. Well, Dr. Doe in her 2014 paper showed that within minutes, human fibroblasts start to have biologic reactions. And so my recommendation is we need to be cautious with it. It's a valuable tool in medicine, but like everything in contemporary medicine, the use needs to be a bit tempered for patient safety.
You covered a lot there. It's great. I was about to mention on the cancer side, recent evidence has shown that you can have this accumulation of gadolinium in brain tumors and in and around the areas of these brain tumors with the healthy cells affected as well. What effect might this have on prognosis and possibly even recurrence of disease? You mentioned about effects on the Warburg effect and maybe insulin resistance and all these other factors, but just in general, what kind of effect might that have? Obviously, we can't say for certain, but it's maybe, I would suggest, possibly an area that needs to be thought about.
Right. Yeah, I cannot answer that, but that does lead me to a counter argument. So we know since 2014 that the gadolinium, it's shuttling into what I would imagine are very important portions of the brain, like the dentate nucleus. The regions of the brain, I can't list how many regions of the brain seem to sponge up this gadolinium. It's the dentate nucleus, it's the pons, it's the thalamus, it's the precingulate gyrus, the postcingulate gyrus, red nucleus. There was a paper recently that showed it diffusely in the cerebellum of humans. In the same paper, they found it in facial nerves. And so for those who believe that this is without any consequence, if it's inconsequential that these gadolinium-based contrast agents just go directly to the dentate nucleus, this is miraculous, and they should capitalize on that. If we're wrong, and if having retained gadolinium has no physiologic impact whatsoever, there's a gold mine here in that you can give this intravenous compound and it goes straight to the dentate nucleus. That's remarkable. But for the people who are claiming, oh, well, there's zero symptoms, there's nothing to worry about, they never go the next logical step, which is we need to understand how this stuff gets straight to the dentate nucleus. It starts forming these electron-dense nanostructures, these spiculated nanostructures. And we need to discover how the neuron is able to survive with that process going on completely intact. There's not a single other metal that has those properties. So one way or the other, people need to be unbiased with respect to the approach to these contrast agents.
Do you know what might be the early symptoms of this? When I was having this as a contrast agent, a few years ago, I decided to stop because I had this strange taste in the back of my throat, and I would feel quite dizzy for a while after having the scans. And I communicated this to my oncologist, and he said that we didn't really even need, there was no actual necessity to use them, and the symptoms I was describing were somewhat concerning to him. So we decided that going forward, I would no longer have this contrast agent, and that it would be perfectly fine to look at my scans. I'm just wondering what might early symptoms be that people could look for.
You know, I can't say. I can say anecdotally the description by Dr. Richard Samelka. People do describe brain fog. I would imagine that since the stuff is accumulating in brain neurons, just about anything neurologic could show up. We also pay attention to the FDA adverse event reporting system. So there's a public dashboard. It's publicly accessible information, and you can take a look at all the symptoms that people report. And there's a good amount of nausea. There's a good amount of different neurologic symptoms. But the taste is interesting. So did that ever resolve in your case?
Yeah, it resolved a few weeks after I stopped having it.
And so what contrast agent was it that you think induced the symptoms? Did they tell you the brand name?
I was just told it was a gadolinium-based contrast agent, but I know there are various forms. I didn't know which one it was.
Okay.
But
Yeah,
the more
so in the United States, all these symptoms we could report to the FDA adverse event reporting system. And this is what I tell people to do. And it's international. You see countries all over the globe where they've got reports. So I think it is important for patients to list these things. And when the FDA officers are looking at the data, they may be able to pull out clusters that signal the system that's being affected.
when gadolinium is used, I was just wondering, what is there that we can see with it that we can't see without it?
Right. You know, as I know, it's vessels. It highlights vessels. Dr. Doe, any?
Thing that is, I guess, water dense compartments that are
Right.
water dense that would need the contrast to help provide differentiation a little bit better.
Yeah. So the mechanism, gadolinium is an amazing element. It's the most paramagnetic element that we have that's practically available. And it has this interesting effect on neighboring water molecules, which from what I understand is what's giving the signal is by how it polarizes the adjacent water molecules. And that's a benefit of having it, is because most of our body is water. And so that provides a great signal.
Yeah, it makes me wonder, just as you said, what's happening physiologically, because we're kind of magnetic beings, aren't we? So just the effect on this water is interesting. Is there any way that maybe we can reduce harm from these agents? You mentioned having the lowest dose possible. Is there any other thing we can do? They suggest drinking lots of water.
Right. Yeah. So from the way that these agents are handled, they actually are cleared by the kidney almost entirely. Now, one of the brands has a little bit of liver excretion, but still the kidney is almost always the workhorse for agents like this to get it out of the body. And so the curve still follows what it would look like if it was kidney elimination. And so the drinking of water, you would want to have something that increased the glomerular filtration rate, which is how we gauge how well the kidney is working. And it's really hard. If we had good medicines, good strategies, or we could manipulate that glomerular filtration rate, we would be employing them left and right where we could. But normally it's just a physiologic process. So even water, when you drink water, you excrete the water, but that doesn't impact your glomerular filtration rate to a significant degree. So if you have to have the agent, your kidneys are functioning, it's great because the kidneys are going to do their job and get rid of the contrast. And so this brings us back to our prior discussion we don't know if that's beneficial or not because we don't know the threshold that it takes to induce irreversible symptoms. We studied bone marrow. Bone marrow understands that it has seen the gadolinium before. I'm worried that just a molecule or two are able to trigger this systemic effect, and we don't know what that threshold is. So therefore, we may be too late once we get it. So in our field, there's a big debate whether you put someone on dialysis after they've been exposed, if they have severe kidney disease, or if they're a dialysis patient. And so with my comfort is limited to, let's see if we can do the exam without the gadolinium so we don't have to deal with that. Maybe you can get your answers without it, number one. And then if someone does get it, I don't think we'll ever be able to scientifically determine the right answer, given the low numbers of patients that develop the full-blown disease. And then we would have to do a prospective trial to see if any of these additional maneuvers are beneficial or not. Because every time we do something, there's also a risk for harm as well. And so drinking water, it's something I recommend for patients who have kidney stones. I guess to a certain degree, it's okay. It's a benign recommendation, but then again, I can't say that that's doing anything with respect to the gadolinium clearance.
Okay. As an additional note, how do you see the future with all of this? What do you hope to see?
So I think this is a wide open field. There's not a lot of people studying the biologic effects of this. Radiologists are definitely concerned about it. I think they're more concerned than the colleagues in my own specialty. They're trying to do everything to avoid gadolinium. They're using artificial intelligence. They're developing other forms of MRI contrast. I have to say that the gadolinium is a very unique element. If we understand more about the physiology and the pathophysiology, we can actually help design safer contrast agents. The last agents, the debut in the scientific literature was in the 1990s, like 1994. They haven't designed anything brand new. And so we need to know why these diseases occur. We need to define gadolinium deposition disease better. We need to see how long people are retaining the gadolinium, if everybody retains it for years, or if there's people that clear it more rapidly, and if those patients seem to be impervious to symptoms. So there's quite a bit of research that needs to be done in this area.
Yeah, it sounds like it. I noticed that there's been, in more recent years, just more and more evidence gathering on this. Why do you think that is, considering there was this long period of time where it was just deemed completely safe and there were no concerns about it? Why do you think only now there's this concern? Is it because it's been so many years, so they're able to see the long-term effects?
Yeah, I think human beings, we're very bad at picking up weak signals. And I think that's clear. That's why people are interested in artificial intelligence, machine learning. I think that from our specialty, nephrology knows what the trace elements are. We know that rare earths are not part of it. Perhaps we would have been able to investigate this earlier. But I think a notion was that the stuff was 100% removed within 24 hours. And so people didn't pay much attention to it. But now that we're finding the metal within human cells, you find it within neurons, this warrants some attention.
Are there any conditions that maybe you would have more concern about having the gadolinium than others? You mentioned possibly if you have a compromised blood-brain barrier. Are there any other areas of caution like that that you can?
Even I think we don't know a lot. And even in that case, even if you have a healthy blood-brain barrier, it still gets in the cerebrospinal fluid. So I don't have any recommendations. I do think that we need to start tallying all the gadolinium-enhanced images that were collected, and we didn't get any actionable diagnosis. I think that's a very important thing for us to count.
You also mentioned patient reporting of their symptoms. Is there anything? Firstly, where can they do that? And secondly, how can we effectively gather enough data, not just of symptoms, but also you mentioned MRIs and maybe other methods of assessing this retention and the subsequent effects. I forgot what the question is, but how would we gather all this information?
So I like the centrality in the size of the FDA adverse event reporting system, and patients can report their symptoms there. It's nice. Anything that's published case reports are very valuable. You know, you get more detail about the quantity and the setting that the exposure occurred, and then the subsequent symptoms. Is there anything?
The only way that we would actually get more data, concrete data, is if we have a centralized health record system in this country.
Yes.
Where you would have a registry of people that are getting MRI with contrast.
Did you hear that from Dr. Doe?
Could you just repeat that? Sorry, it's quite
So
quiet.
is centralization of the medical record could be beneficial, and so this is what we're trying to get off the ground with the VA data, and yeah, it's going to be important. If these symptoms are subtle, you need a lot of patients. So the laboratory work is very important, so we can understand where we're going. But also patients reporting what they have. There may be a system that we're not paying attention to that will be revealed by patient symptoms. So this is one thing that I need to emphasize is rare diseases. A rare disease is not insignificant. You know, in my field of nephrology, about a third of our test is on Bartter syndrome. Right? They've got this. It's a rare genetic disease called Bartter syndrome, discovered by Frederick C. Bartter. He passed away of a hemorrhagic stroke in 1983, but he described this salt wasting nephropathy. And it's not something that I've ever seen in my lifetime. I've seen some other genetic conditions, but not Bartter syndrome. And yet, a third of the nephrology board exam is based on Bartter syndrome, a very, very rare disease. That doesn't mean that Bartter syndrome is insignificant. We learned all about how the kidney handles sodium and chloride and calcium and the cell signaling that's throughout the thick ascending limb of the nephron, based on this man's interest in a very, very rare disease that is now termed Bartter syndrome. And so we're dealing with the same thing. This is a rare earth element that is inside the body. If it's not having any physiologic effect, that is every bit as interesting as if it is inducing a pathologic effect. And so I think a lot of this is going to be from our laboratories.
Great. I think we covered just about every question that I had and more. I'm interested in what you said about bone marrow too, because that would affect so many things, including immune function and response to therapies. So if you're using this for cancer, to dictate cancer treatment. So yeah, I think that was very interesting to me. I would love to read more about your research on that. Is that available now? Have you published this?
Yes, almost all of our publications, since they were federally funded, they're available. Free of charge through the agreement with the NIH and the VA, and so that's all publicly accessible.
Great.
So and some of them are on embargo. They may be released in a year or so.
Okay. Well, I think we'll leave it there. Thank you very much for your time, Dr. Wagner, and your team as well. I really appreciate you being able to discuss this with me. I feel like it's, as I say, I feel like it's such an important thing that we need to increase awareness of. And I do think, I agree that we need a lot more data on this.
Right.
So I hope that that happens. Are there any final words that you would like to communicate to my audience?
Well, Andrew, I really appreciate your podcast. It's a fantastic podcast. It gives the patient voice, which is absolutely critical. And so you're doing the world a fantastic service by doing this. And we really appreciate the opportunity to talk to you about this. Do we have anything else, team? No? Fantastic. So if anybody wants to donate to the Kidney Institute in New Mexico, they can, and we can keep this research going. We should have a website that's live to accept those sometime. I'm hoping before the end of the year. So, and that's Miss Julie Harris.
Great. I'll provide a link to that below.
Fantastic.
Thanks again. I really appreciate it. And
Andrew, it was great talking to you. Thank you.
Thanks again. Have a good day.
All right. You too.
Thanks. Bye.